Morales. I'm the branch chief of counter-narcotics at the U.S. Department of State, and this is the Global Coalition meeting, Subworking Group 3.2, to address and engage people with substance use and substance use disorders. This is the East session for the month of April. I have a few administrative announcements to get us started today. We are going to review the meeting schedule. We are going to talk about the website. We're going to be looking at initiatives and how to adopt measures. We're going to be looking at the recommendations. And today we are finalizing the recommendations. So we're very excited to move to the next chapter of our coalition. And to do so, we need to start by saying thank you. We want to greatly appreciate and value your partnership, your participation over the coming months and over the past months. I know it's been quite an intensive series of meetings, and I know that some of you attend multiple sub-working groups. We are very appreciative, and it's a reflection and a testimony to the seriousness of the issue of synthetic drugs. They are worsening around the world. Even during these past months, we have seen growing challenges, increases around the world, new synthetic drugs emerging and rapidly spreading. Just last week, we saw a national health emergency declared by the president of one country. It was the president of Sierra Leone for a synthetic drug that they're facing called Kush, which is quite out of control. And we're seeing this around the world in more and more countries. We have our own significant challenges in the United States with opioid overdoses as well, fentanyl overdose. So it's of great concern. And while we have these great challenges, we also see that there is a lot of enthusiasm, energy around addressing this issue from the international community. For those that were at the Commission on Narcotic Drugs, we heard national statements referencing synthetic drugs and the Global Coalition. We had 2 Global Coalition meetings that included a donor coordination meeting as well as a general catch-up on the coalition. And we heard many side events as well from governments, from civil society, and from international organizations. And one civil society, the Global Initiative for Transnational Organized Crime, had an interesting map that I wanted to share with you all. This map shows in red where illicit synthetic markets have been increasing in severity in the last 2 years. And the orange is where they have remained unchanged. It's only in green where you see there's been a decrease in severity. So the picture is becoming worse. It's growing in terms of concern, and it requires redoubled effort. In the coalition, we are now in the action planning and implementation phase that will take place during the months of April, May, June, and July. You may ask what we're going to do during these months. Well, we will be sharing national experiences. If you are interested to present on a topic of what your country is doing, please follow the link in the chat that Sarah Finmore, our colleague, is going to paste, or you can see the one in this presentation, and please register your interest, and we will do, to the best of our ability, slot you into one of the sessions for the coming months. We will discuss continuation of the initiatives, the global initiatives, and begin these initiatives. We will also be looking at engagement of other sectors, civil society, for example, for this working group, or the private sector for the manufacturing and trafficking working group. We will also be looking at other opportunities for training or workshops if we have enough time. But if we don't, no worries, we'll look for other opportunities, and we will invite you, all coalition members, to some of those great training workshops that the UN and others offer governments. So we are looking at recommendations today. We currently have 60 of them, and it looks like that might be the final number. What we are doing today is finalizing these recommendations in this working group. Those recommendations will then lead to actions. Those actions can also be considered measures that we are adopting. We're going to ask all of you colleagues to demonstrate your actions in support of the recommendations. And you might ask, but what is an action? How do we classify that? What specifically are you looking for? Well, the first category would be by having you express interest in some of the initiatives of the international organizations. You may ask, where are these? I'll show you in a moment on the website, but currently we have 115 initiatives across all of the sub-working groups. Another way might be to provide bilateral or international organization support. That support can be financial, or it can be in-kind assistance, helping bilaterally a country or an international organization to work multilaterally on a synthetic drug topic. You might also consider the adoption of a new practice, a policy, a regulation, or a law. Also, you might consider engaging and collaborating with the private sector, or you might choose to host a regional meeting or a global meeting for the Global Coalition on a thematic area of interest. So we're going from actions that we are identifying in this month of April and begin the activities, the international activities, initiatives between the months of April and August, and those will lead to achievements. And these achievements will be, of course, preliminary. We will start convening countries across multiple lines of effort, and they will start advancing in their initiatives, in their projects, in their programs, and in their actions. And then we will produce a year one report. Beginning in July, we'll start drafting it, and then in September at the UN General Assembly, we expect to share that report with colleagues. Then from October onwards, we begin the second year of the coalition. There we will enter the full implementation phase, in-depth programmatic initiatives and actions that then will lead to concrete outcomes in time for the year two report, which will be in September 2025. So where do we find these 115 initiatives? On our Global Coalition website, you will see that there is a tab called Initiatives. If you click on that, you will see a listing of all of the activities by sub-working group that you can participate in. I encourage you to look at these in detail. Here's one, for example. It has the title, it has a description, accomplishments, the specific activities of the project, what are the outcomes that are expected to be achieved at a global and national level, and which countries are participating. You might see your flag and say, but I'm not participating, must be somebody else from our team. If you are interested in participating, you can still feel free to write to the email address, ask who else might be participating from your country. You can offer your interest to participate as well, and the international organization will do their best to incorporate you into these projects. Now, in some cases, the participation will require much more intensive financial support. And so those resources may or may not be available, but if they're not available, the international organization will inform us, and we will work with a series of donor partners to see if it's possible to further expand that support. And so hopefully we'll be able to identify those resources. But I want to emphasize that just by making an expression of interest, doesn't mean that resources will be available to practice. Now, I want to also offer a new feature on our website and invite you all to engage on the Coalition Discussion Board. Registration emails have been sent to all coalition members through the email addresses that you all provided when you registered. If you have not received the email or misplaced it, no worries. You can email us at syntheticscoalition@state.gov, and we will send you a new link so that you can register for these bulletin boards. How does this look like? Well, at the upper right-hand corner, you will find the place where you can log in once you've established your account. You will provide your username and password, and then you will see at the upper right-hand corner that you will be logged in. You'll have a profile button. There will be a community button, and if you click that community button, it'll take you to your page where you can put your own banner. I added Washington, D.C. to my backdrop. You can add your photograph, and you can then add as many of these sub-working groups as you are interested in. If you click on 2.2, for example, I did here, that takes me to a wall, a news feed, and you can then just go straight in and say something to our group. You can add some images, documents, what you wish, and post it. And when you do so, I posted one here, for example, about the public health crisis the public health emergency that was declared by the president of Sierra Leone. And then I added the BBC News article that then generated the image. And then you can see at the bottom, you can comment on that article on the posting I did. In this case, our friend Donald Conte from Sierra Leone wrote to us. And then you can have a free-flowing conversation, questions, documents you can add, and that will help facilitate our discussions outside of the monthly meetings that we have. So that is a new feature. I encourage you all to use that. And now I want to move on quickly to the recommendations. For the recommendations, I want to begin with this, what we call chapeau, or this preliminary text that will be added to the website and to our document. And it reads, the recommendations herein are non-binding and for future government consideration where appropriate. They reflect the views of technical experts participating in the global coalition and do not reflect a consensus of governments or a single national position. We added this here because I know many of you participate in C&D and negotiate resolutions. This is not an internationally negotiated set of recommendations at the national level. We're all technical experts, albeit representing our governments. And so these are our views, our thoughts as technical experts of where we think the coalition can be effective. The purpose of these recommendations is so that we can have initiatives, as I described previously, that can support or point to something, so that there is the rationale of why we are doing these initiatives. And so that is what the recommendations are here for. So with that, I will move to the recommendations for 3.2, and I know we reviewed them in March, so I will only read those that are new. And so these are the new, or the edited, I will say, recommendations. 36, expand naloxone availability and access with communities as well as health centers, including training for practitioners and active users, first responders, and other groups that are likely to encounter an overdose to prevent overdose deaths. Promote overdose intervention programs where appropriate and in accordance with national legislation and regulations, and develop data reporting systems regarding naloxone provision, both within the public health system and by first responders to further evaluate their impact of the availability. 37. Work together with relevant stakeholders, either government or non-government, to support the registration and procurement of essential medications in addressing drug use and drug use disorders, for example, methadone, naloxone, etc., in interested countries to address market-driven shortages. 38. Develop and implement scalable interventions for the treatment and care of stimulant use, concomitant use, physical and psychiatric comorbidities, and other emerging drug use disorders, including contingency management. 39. Expand access and improve coordination between promotion, prevention, screening, early intervention, treatment, care, recovery, rehabilitation, and social integration services for all, and particularly for marginalized communities or vulnerable populations. 40. Promote evidence-based treatments for substance use disorders, adopt national quality assurance systems of care or national standards in treatment in countries where it has been established, based on the UNODC WHO international standards for the treatment of drug use disorders. 41 has not changed, so I won't read that. 42, develop and implement age and gender responsive women's prevention, treatment, and recovery services where appropriate, and concurrently expand and improve the quality of the workforce providing these services. 43. Develop strategies and guidelines, including for public, law enforcement, and local communities to increase the understanding of substance use disorder as a disease and to recognize and reduce substance use disorder-related stigma as a barrier to treatment and social reintegration. 44 has not changed. 45, promote a national comprehensive treatment system and national recovery network with support for local implementation involving relevant stakeholders, such as local political authorities, local government agencies, education, health, social affairs, culture, sports, public security, among others, the community, and local social organizations. 46, create and promote a system for continuity of care for persons with substance use disorders, including identifying and strengthening each level of care and addressing local needs. 47, implement integrated systems or mechanisms for recording information to monitor and evaluate treatment services. 48 remains the same. 49, differentiate consumption patterns according to their intensity and associated risks for the individual and for society, and develop specific interventions targeted at different patterns of use. 50, identify the gaps in providing care for the population with drug use problems with emphasis on synthetic drugs. 51, integrate the care of people with drug use problems into mental health services. 52, integrate services for co-occurring mental and physical disorders in the substance use disorder service delivery. 53, leverage digital technology to augment the capacity building and service delivery initiatives. 54, establish collaborations across the non-health sectors, unorganized sectors, traditional health systems, religious and faith-based organizations to strengthen the services for substance use disorders. And that is all. The others are for the next sub-working group. So that was a lot. I will stop sharing my screen. I have our co-chairs that are here, so I will turn it over to them and ask them if they want to moderate the discussion to see if there's any questions or comments or feedback on behalf of these recommendations, and they can post them in the chat. If not, then we can move on to the rest of the agenda. But I'll turn it over now to our colleagues Yetan Balhara and Amrita Devi to then take over. Thank you so much.
Thank you, Brian. Thank you for giving us a very comprehensive overview of what we have done so far. And it's really heartening to see that we have achieved a lot. At this point, I would like to invite your comments, your suggestions on these recommendations, anything that you would like to comment upon, or even suggest a new recommendation at this stage. Please feel free to do so. You may like to either speak, or you may type it in the chat box if you prefer to type. I know it's quite a few recommendations that we have come up with, but I believe they are quite comprehensive and they cover a lot of themes that are centered around the treatment part. Yeah, I can see one hit in the chat box at any point during this session. And let's move ahead with the presentations that we have lined up for you for this session. As has been the tradition, we'll have 3 presentations in this session, and we look forward to your comments and questions on these presentations. We'll take up the questions and comments after we have completed all 3 presentations. Or if you want to speak, you can wait till the end of the 3 presentations. If you prefer to type in your questions or comments, please feel free to do so at any point in time during this session. May I request Dr. Amrita to kindly take us through the presentation section. Thank you.
Thank you, Professor. Yes, without further ado, we can start. I'd like to invite Dr. Yatan as our first speaker here from this session to talk on leveraging the digital technologies for strengthening capacity on prevention and management of substance use and substance use disorder. The floor is yours, Doc.
Thank you. Thank you so much. Thank you for this opportunity to share our work that we have done at our center in India. And in this session, I'll be focusing on how we can leverage upon digital technology to strengthen the capacity in the area of prevention and management of substance use and substance use disorders. As we all know, there is a very strong, very important interface between digital technology and healthcare. And when I say healthcare, I mean healthcare in general. It's applicable to every discipline of medicine. And COVID has taught us that this interface, this interaction is a very important interaction and interface, and we need to strengthen it going further. When it comes to this interface, digital technology can be of use in context of healthcare in multiple ways, in more than one ways. One of the ways it can contribute is by creating interventions that are digital in nature. So that means that we can create some interventions which are available on digital platform. It can be over a website, over an app in our phones or a tablet. So that's one set of interventions where digital technology can be of great use and utility for us. The second theme where digital interventions or digital technology can be of great utility is digital spaces. They offer a unique platform, for example, telemedicine or teleconsultation. Here, the intervention remains the traditional or typical face-to-face or in-person intervention, but it is delivered through an online platform. There is another third way or a third dimension in which digital technology can be of great utility in context of healthcare delivery, and that is in terms of capacity building. And by that, what I mean is that digital technology can be utilized to strengthen the capacity of workforce to deliver these interventions. And in today's session, I'll be focusing on specifically this element, that how we can leverage upon digital technology to strengthen our efforts in terms of capacity building, both for management as well as prevention of substance use as well as substance use disorder. So I'll share with you some of the initiatives that we have taken at our center. I work at a publicly funded university. It's called All India Institute of Medical Sciences. It is located in New Delhi. And we have a specialized center called National Drug Dependence Treatment Center. Around 6 years back, we established an e-health facility at our center, and it is called ENDDTC. So it happens to be housed in a specific room. We call it telemedicine room. So this is one avenue through which we offer our services and our interventions. So we use this space to host online sessions, and we have participants on both ends. And there are multiple spokes that join us in this hub and spoke model. But that's not all. As part of this initiative, we run a website which hosts all our resources. It provides information on what we are doing. It provides a lot of content, and I'll be offering a glimpse of that as I go along in this presentation. And finally, we have a third component of this e-health facility, that is a learning management platform, where we host different courses, different structured courses that we provide as part of this initiative. Now, over the years, we have grown and we have introduced multiple initiatives as part of our endeavor to strengthen the use of digital technology in capacity building initiatives. So one set of resources that we have created is centered around creating this content that is available 24/7 at our website. So we have created different modules. For example, on this slide, you can see that we have created modules on management of opioid withdrawals, management of alcohol withdrawals, and other resources that we have created at our university. So these resources are available and at our website, and anybody can access them free of charge, and they are available. You can access them at your own time of preference and whenever you are free to access these services. So this is one set of resources that we have created. In addition, we have also created some structured courses which are hosted at our LMS. For these resources, you need to register first. There are some eligibility requirements that you have to fulfill. They are not very stringent. They are quite simple and very relaxed. Again, it gives you an opportunity to access this course at a time of your choice, from a location of your choice, and you can access these courses. For example, this particular course is on screening and brief intervention for addictive disorders. Similarly, we have other courses as well. For example, this one is on management of substance use disorders. It's a much more comprehensive course which takes people through different modules which are designed to manage different kind of substance use disorders. There are other set of initiatives which include real-time or synchronous trainings. For example, this is a snapshot from a particular training that we did for school teachers. And this was conducted in the local language Hindi. And this is a real-time online sessions that we conduct for school teachers. Again, we make it very interactive. We have different quizzes, interactive sessions, uh, helping people get to know the different terms. We create group works and we carry out in specified time slots during a period of day during a week. So we have carried out these synchronous sessions on training as well. We have worked with certain state governments as part of their national mental health programs, and we have come up with some hybrid models as well. In these hybrid models, there is an element of an on-site face-to-face training where we train the participants over a course of 2 to 3 days in in-person setting. And then we take the training forward using online platforms where we have weekly sessions with them, where we have case-based discussions, we do mentoring, and we even conduct didactic sessions for them. So this is a kind of a hybrid model where we have both in-person sessions as well as online sessions. We have collaborated with WHO as well, with the regional office in Southeast Asia, and we have created this resource on management of alcohol use disorders. This again is available online, and we have created different training modules for medical doctors, for nurses, for clinical psychologists, and even for primary care workers. So we have created different modules which cater to the needs of different cadres of healthcare professionals. Uh, Again, with WHO, we have created another online resource. This is known as Mental Health and Addictive Disorder Southeast Asia Telehealth and E-Resource Hub. We know it by the name acronym, with this acronym MASTER. And here again, we have created resources for different substance use disorders and some common mental health conditions as well. Again, these are quite comprehensive. We offer details on the epidemiology. We offer details on the assessment, diagnosis, and management of these conditions. And we also talk about prevention of these disorders as part of this online platform. Finally, in more recent years, we have started working on behavioral addictions as well. And again, we have collaborated with WHO and created this resource on addictive behaviors. Again, we host different kind of content there. There are videos, there are interactive sessions that we conduct. We have created resources to guide people through healthy and safe use of internet and technology. And we also post academic publications that we have created on these topics over the years. We have had some important learning with this experience. We have realized that digital technology is a great tool, not only for delivering healthcare, but also to strengthen the capacity of the workforce. It has a very good acceptability, a very wide reach. It's possible to scale it up easily with limited resources, and there are diverse models that can be utilized. And we believe that this can be extrapolated to the synthetics as well. We can take this interface and use this interface to develop interventions, create platform for delivery of care, as well as to capacity building initiatives when we talk of synthetics as well. And before I conclude, I would like to acknowledge our project staff, our funding agencies, and the participants who have supported us in implementation of these models. So I'll stop with that, and I'll like to take any questions or if you have any clarifications from me on this. Thank you so much.
Thank you, Dr. Yatan. Indeed, the digital technology in various countries, it comes with various names: teleconsultations, telemedicines. It has a very comprehensive, extensive reach out. We understand that in the future, I guess this will be one of the core methodology in healthcare delivery in the future, and to extend care from traditional face-to-face interactions between patient and clinician. It can also reduce costs and improve outcome, yeah, and as the tools of monitoring, as you mentioned, on the intervention that has been provided. Thank you, doctor. And I shall proceed to my own presentation. Um, do I do my own screen share?
Yeah, if you would like to do that, please do.
Um, Okay, is it visible now?
Yeah, it's visible. Please go ahead.
Okay, yeah. I would like to share actually Indonesia's experience on the implementation of national standards that we have established over since 2019 and has received various inputs and modification in the implementation, and we have come up to the newer version of the national standards that has been established for treatment and rehabilitation services. And as an overview of how this national standard came into uh, implementation is, as we understand in Indonesia, they are, as we understand in the addiction field, they are medical treatment and social rehabilitation. So in Indonesia, we have the Ministry of Health, who is in charge of the health aspects on the medical sides of treatment and rehabilitation, and we have the Ministry of Social Affairs in charge of the social rehabilitation. And we have BNN as the national focal point for drug matters. So if you see, there are various agencies and also various regulations in implementing these standards on how treatment is implemented in Indonesia. And with a vast population and also the largest archipelago with hundreds of indigenous cultures, there are various traditional cultural approach that is not evidence-based. So there's this national government body that overlooks the implementation of public services in Indonesia. We call it Ombudsman. It came into their attention on how treatment approaches have been implemented in Indonesia, and that therefore, subsequent to that, through an interministerial meeting, we have agreed to design national standards for rehabilitation services, and therefore establish a national technical committee who is responsible for the drafting and the implementation of the national standards in the future. And we call it in Bahasa Indonesia SSNI. So it's Standar Nasional Indonesia, under the supervision and guidance from the National Standardization Board. So there's this coding of 8807, which is especially for treatment and rehabilitation services. And the first version was established in 2019. And these are the members of the technical committee of the national standards in treatment. So it represents the whole aspect of the stakeholders involved, from government agencies and institutions responsible to deliver treatment and rehabilitation, who we called as producers, and also expert components, and also the consumers. These consumers are those who gain the benefit from the services being delivered. So it's not only so if you see, this is a committee that is consists of various stakeholders who is relevantly in charge and has great concern in the implementing of treatment and rehabilitation services. So along the way, somehow, the earlier version in 2019 is very complicated, is not completely applicable. There are various treatment centers, especially in the rehabilitation, social rehabilitation aspects, the countering difficulties in the implementation of the initial version. So therefore, after 3 years of implementation, we did a revision and comes up with the SNE 8807 2022. This is the latest version, which it comprises of various scopes, various contents, which comprise of the definition on the medical and social rehabilitation, where each aspects have in and outpatient services. And the other component is on the program being delivered, starting from initial intake, that is assessment, screening, crisis intervention, up to a social integration program. And we also classify eventually the treatment centers into type 1, type 2, and type 3, where these individual types have various services to cater to inpatient and or outpatient services. There are a few requirements. The general requirements consist of organization of the um, centers itself, the principles of services, referral system, and how reporting, recording, and evaluation of the services is being conducted. And specific is on the specific treatment modalities that has been delivered, which is based on the various aspects as well, utilities, and then the medical intervention, psychosocial intervention, human resources qualifications, among others. And the miscellaneous aspect is how we measure the outcome of the treatment services being delivered. We use our national index of satisfactory uh, instrument, and we also use the WHO quality of life as a tools to measure the progress of the each individuals. We have a addiction severity index and also assist. These are the instruments, part of the instruments that we use to deliver, to measure and also to monitor the services being delivered. If you look at the general requirement here, we see on there are compulsory aspects that is embedded in the organization, or each and every centers need to have the legal aspects, services based on human rights, and also um, data recording, reporting, referral system, network system, service evaluation, and emergency management. On the compulsory intervention that has to be delivered by each center, starting from informed consent, screening, assessment, treatment plan, monitoring, referral, and also uh, building networking with the relevant agency that is available, especially within their vicinity. And also compulsory facility, including sanitary facility, environment, lighting, clean water, safety of electricity, and other appliances. So these are actually the main, the foundation that is compulsory for every center to have in the implementation of the services. And these specific requirement, if we see here, we see from various aspects. We have the utility aspects, the intervention, and also human resources. The utilities comprise of the rooms or facilities that is in within the centers itself to support the implementation of the services being delivered. So uh, it is essential to have uh, main rooms and supporting functional rooms for, be it inpatient or outpatient, for registration, waiting room, counseling, education, and administration. Specifically for inpatient, of course, we need to have a rooming in inpatient room and crisis intervention room. Other supporting rooms and facilities including lactation room, toilet, medicine cabinet, filing cabinet, oxygen tube, fire hydrant, ambulance, and telephone. Although in most areas, mobile phone is very convenient instead. And also the intervention, we divide it into medical intervention and also psychosocial intervention. So medical intervention is basically conducted in the centers that is in the form of clinic or hospital based, where they need to be able to deliver withdrawal treatment and comorbidities. Psychosocial intervention includes individual counseling based on approaches, either motivational, interviewing, and or cognitive behavior therapy, group counseling, education, family approach, relapse prevention, and crisis intervention. And also in the human resource aspect, we again categorize it for the treatment centers that caters with medical intervention. Uh, Specifically, they need to have medical doctors, be GP, specialist doctors, mostly psychiatrists and internal medicines, nurses, and pharmacists. In social settings, psychologists, counselors, addiction counselors, and also social workers. In Indonesia, we do tra train periodically, annually, those who are involved as counselors, and also we have a competence examination every 2 years for them, although it is conducted annually, but each certification lasts for 2 years. So in every 2 years, they need to renew their certification. And finally, the classification based on what has mentioned earlier, the service settings we divide into type 1, type 2, and type 3. Type 3 is the minimum standard, and type 1 is those that has a comprehensive integrated services and also networking. So it is classified in each type. It caters for outpatient specifically, inpatient specifically, or they can have a combination of services of in and outpatient services. So these are the process, if you see, of standardization, what we do on annual basis. So the first the first 3 months of the year is basically identification of centers, determining the locus, and also building the team who will be involved in the providing technical assistance for each center that has met the requirement to proceed to the national standards of treatment. And in the month of April to September, this is where we start procuring assistance on services in line with our national standards, and also technical assistance, trainings of counselors, and monitoring each assistance delivered periodically. We do have officials, so we not only train the officials who will be implementing the program, but also training of those who is in charge on supervision and monitoring of the services being delivered by the counselors, addiction counselors, medical doctors, and so on. And then the month of October up to December, this is where we start to provide more intense evaluation, providing feedback. And usually in the month of November to mid of December, this is where we start scoring on the achievement of various services based on the setting components. And towards the end of the year, we identify them, which one falls under type 1, type 2, or type 3 of the national standards of services. So these are the type of technical assistance that we provide. Tutorial, coaching, bedside teaching, case studies, making more interesting to them, not just two-ways trainings, but also trainings being delivered based on the experience that they encounter on day-to-day basis. Role playing, and then analysis of documents. This is where we go very in-depth, confirming what is being written with what is being implemented. And at the same time, providing observations on what has been recorded, conducted systematically in delivering the services. So these are the achievement of the national standards of rehabilitation that has been done since 2020 up to 2023. To date, that we have 910 facilities that is under our supervision. Is as we see here that majority, because of our limited capacity, have not been standardized. If we see in 2020, there's 1%. There's an upscaling of the treatment centers, treatment and rehabilitation centers that has been standardized by us, but if you see, majority of it is not being standardized. So these are the, we'd like to break down on the centers that, if you can see here that there's an extensive treatment offerings actually based on medical aspects and also social aspects. If we see here, we classify this as centers that is under BNN supervision. So we have 6 inpatient in BNN itself, 6 inpatient centers, and we are running 207 centers throughout Indonesia. And these are the centers that we run. The outpatients of 207 centers that provides outpatient services are all, the status is clinic. So more on the medical provisions and social rehabilitation at minor, but individual intervention is being provided. And if you see, all in all, there are around 420 centers that have been covered by us to provide services in line with the national standards of treatment and rehabilitation services. And in the process, we do face various challenges and constraints. So far, lacking of cross-ministerial coordination. I think it happens everywhere in the part of the world. But however, understanding that we do have a national standards, we do need more support from the various ministries who are implementing treatment and rehabilitation services to expedite the implementation of national standards, limited awareness of services providers and consumers on the importance of service based on standards, and limited reward and appreciation to service providers, a wide range of human resource capability, and limited opportunities for trainings and improvement or enhancement of capacity building. And these are the challenges that we face. Of course, we need the support to facilitate treatment owned by the community on the implementation of standards, and commitment from stakeholders in the form of regulation, and continuous updating of evidence-based treatment choices in line and with the development of substance use and trends. So these are in 2023, before I conclude, in 2023, we received an award from the National Standardization Board on they say, on our excellent implementation on the national standards and our coverage, bearing in mind with all the limitations that we have and the constraints and the support, minimum support as well. So we understand that quality assurance is very much on the highlight in the UN, but we have come so far way advanced than just quality assurance. Quality assurance is part of the national standard that we have implemented in Indonesia. And with this also, we are open to all supports, and especially enhancing capability and capacity of our human resource to deliver more professional services for our fellow friends who are suffering and in the process of recovery from substance abuse. I thank you.
Thank you, Dr. Amrita, for this comprehensive presentation that you have made. It seems to be a very exhaustive process that you have taken, and it has come out really well. And we hope that it builds up in future as well.
Thank you.
So we have a third presentation lined up for this session. I think we can squeeze it in. It'll take us around 8 minutes to finish the third one. So this third presentation is on global recovery networks, and the presenter is Mr. Michael Botticelli. So can we have the presentation, please?
Sorry about that. Just as I was saying, I had the pleasure of working with many of you during my time at the White House during the Obama administration. So it's nice to see many familiar faces and friends today, and really privileged by the opportunity to present to you about kind of recovery. And as you think about kind of moving toward recommendations and implementation, hope that gives you the opportunity to think about some possible recommendations as you move forward, as well as to talk about kind of our new initiative in launching the Global Recovery Network. What I thought I would do first of all, and I realize that many people are very fluent in recovery and what it is and the language of recovery, but just do some level setting, because it can mean drastically different things to people. Particularly even in the recovery community. So I thought I would start there. So next slide, please. So I think it's important to distinguish between abstinence and recovery. And while abstinence is really the absence of use, alcohol or drug use, and mitigation of symptoms, recovery is different. And recovery really means the return, or sometimes the first time for people, to kind of a purpose-filled and meaningful, and some might even say spiritual life. It's seen as a lifelong process, that you're not done. And people will say, I am in recovery versus I am recovered. I also should mention, I assume that people know this, I've also been a person in long-term recovery. So I've been in recovery for over 35 years now. My appointment during the Obama administration is a testament to the power of recovery. This is interesting, and it's really been a dialogue that's been happening lately. While most people would agree that recovery includes a commitment to abstinence, there is some disagreement among civil society and among other folks. So I think that's important to acknowledge. Next slide, please. So in 2014, the SAMHSA, which is the federal government agency tasked with the federal coordination of activities, convened a group of stakeholders to try to develop a consensus definition of recovery. And they did this to apply to both substance use disorders and mental health issues. And that's a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And particularly for this conversation, it has 4 dimensions: that someone has a healthy as possible life, that they have a home, that they have a safe and stable place to live. They have a purpose in life, whether that's a vocation or educational opportunities, but they have a purpose that gets them up in the morning. And they have a community, and a community that loves them and supports them. So those are particularly important dimensions. Next slide, please. So I think it's also important to acknowledge that recovery is a kind of separate and distinct point on the continuum of care. And while the goal of treatment is really to engage patient to alleviate and to eliminate use and symptoms, recovery supports are generally non-clinical services which help people reach that meaningful life. But I also think it's critical, and particularly for this group, to understand that recovery supports are not just direct services. And I think probably the most, at least from my perspective, the most influential recovery supports can be policies or laws or regulations that facilitate that pathway to recovery. So, for example, many people with a history of addiction have criminal records. Sometimes their involvement with the criminal justice system can mean lifelong prohibitions to returning people. Other examples, providing people with housing or housing supports, job searches, peer support, recovery coaching, and educational supports are all examples of kind of critical recovery support services. Next slide, please. So how do we go about building this community? And this is by no means exhaustive, but I really broke this down into 4 distinct components. The first one, as we were talking about, kind of build consensus and normalize this concept of recovery. It can be very, very new for many, many people. Second, and I think this is very, very critical, build the visibility of people in recovery and develop a recovering community. And I can say for myself, addiction can be a very, very isolating event. Sometimes people in the community don't even know that people are in recovery, and building this visibility and community are important. Just as we think about treatment, it's important to build a recovery community infrastructure to support all the things that we're trying to do. And lastly, reduce the legal, policy, and other barriers to people reaching their full potential. Next slide, please. So how do we normalize this? Just as we did here in the United States, and we actually did with our Global Recovery Network, is convene a group of stakeholders to really promote and develop a consensus definition of recovery. It's really important that we have a baseline understanding in terms of where we are. I think important for this group is continue to promote this concept of recovery, its definitions and services in all the international fora that you belong to, incorporate that in speeches, and use that for a vehicle for promotion. I think it's also important that where it's appropriate, including people in recovery in delegations, presentations, panels, the use of someone's personal story really, I think, moves people and shows the power of recovery. I think many of you know the media can play a very strong role in promoting recovery. The way that people in recovery and people with addiction are portrayed in the media, use of non-stigmatizing language. So that's one area. Second area is build the visibility of people in recovery and develop a recovery community. So really supporting and promoting recovery summits and ongoing activities and events. Here in the United States, September is Recovery Month, and all month long we have events sponsored by the federal government, local governments, and regional governments. Develop a speakers bureau to ensure that people who are in recovery are telling their story appropriately, and there are tools and resources out there to help people do that. It's also important, as you see in other areas, by engaging high visibility of people who are willing to come out about their recovery, I think really ends the isolation and the shame and stigma that many people have. Developing media campaigns to showcase people in recovery and highlight the barriers, and really promote the inclusion of people with lived experience in all appropriate events and governance structures. So I think it's important that people are part of our boards, they're part of our service structure, and they're part of our conferences and delegations. Next slide, please. So build a recovery community infrastructure. So support or fund local, regional, or national recovery community organizations. This is something that we've been doing for the past few years here in the United States. Promote or directly support recovery support services. And again, these are really important. And as Brian talked about in other areas, engaging kind of the wider community, civic organizations, academic organizations, employers, to really support community level actions are really critical to our success. We need allies in this, and it's critically important that we engage those people in the work that we're doing. Next slide, please. I think perhaps most important for this group, and one that I kind of want to strongly suggest, is the reduce legal policy and other barriers to recovery. When I was at the White House, we established an Office of Recovery as part of our work. And one of the first things that we did is conducted an inventory of all of those laws and policies and regulations that can inhibit people's recovery. And we came up with over 100 of those items. And to really reduce those, we implemented an action plan to reduce or eliminate them. So we tried to do it. So let me give you an example of that. On our federal financial aid form, which gives people financial aid for institutions of for college and institutions of higher learning, there was a checkbox that people had to check if they had a criminal history, and that could also eliminate them. So we worked to eliminate that criteria from federal applications, and promote the adoption of non-stigmatizing language. Our words matter, and the words that we choose can really portray that this is a clinical issue as opposed to a criminal justice issue. So I think that, so let me end on a high note. Please, Van, go ahead. So we really are excited about the establishment of this global recovery network. And this is a consortium of international organizations that are coming together to provide a platform for our members to build and reinforce recovery capital, which means kind of people's personal and societal support for recovery. We want to promote lifelong learning, forge and maintain connections to support each other, and really advance the understanding and practice of recovery throughout the world. So we're very, very excited about this network. We have a working group and executive committee and are moving toward our launch at ISIP in June. We are tremendously excited by the work. I want to acknowledge, she's actually helping me with this presentation, Thang Yang, who works for Brian, who's really been my partner in making this happen. So next slide. So what are our goals here? You know, just as we were talking about, we want to create connection and community among people in recovery and organizations that do recovery support. This can often be isolating work, and being able to connect and learn from each other is important. We want to continue to promote an understanding of what recovery is and what it's not, and continue moving toward professionalizing people providing these recovery support services through the universal recovery curriculum and through certification processes. And long-term goals really kind of change policy and promote policies that enhance long-term recovery, continue to establish recovery networks at the national and local level, and ensure people in recovery really reach their full potential for health. That's our ultimate goal here and what we want to establish. So next slide, please. So what can you do? As I said, conducting a policy analysis at the national level that either help or hinder people to sustain recovery, to develop a strategic plan to mitigate those barriers, promote non-stigmatizing language. When I was at the White House, we actually sent out a directive to all of our federal agencies to ask them to use this non-stigmatizing language in all of their public-facing materials. And there's great resources about the kind of word changes that people to make. Engage existing recovery organizations and people in recovery to build a recovery network in your country. So those are, I think, are important potential recommendations that this group can come up with. So next slide, please. And here's, we really want to encourage you and all of your networks and all of your contacts to join our network, to promote research-based messaging, to connect with allies and peers, to learn about events, and to join us in Greece in 2024 for the launch of our event. So I want to thank you for your time and for your attention, and see if people have any questions or comments.
Thank you. Shall I take this, Yatan?
Please make the concluding remarks. Yeah.
Okay, so we have heard our final presentation in this session, and it's very interesting how we move from digital technology to a comprehensive approach on how sustainability and recovery is very essential. We all understand that recovery is not about progress. Recovery is about progress, not perfection. That is something we need to keep in mind. And of course, we coming from this part of the world, we are open for any approaches to build a recovery network or organization, especially in our country. And would like to, I know we're short of time, just open if there are one or two questions. If not, then I can move forward to Brian for the final remarks. I see no one raising hands. Let's make this one quick. Brian, floor is yours.
Thank you so much, Amrita and Yatan, and all of the Michael and all of the partners here today on the call for 3-2. We are a little over time, so I'm going to end the session now and thank everybody for participating. And I'm going to ask.